Thank you for joining us for this evening's International Dermatology Education Foundation Educational Series webinar. See the big picture, seen, unseen, and unforeseen. Our moderator this evening is Dr. Brad Glick, member of AAD Board of Directors, Residency Program Director from Palm Springs Hospital, PI for GSI Clinical Research, and ASDS Advocacy Ambassador from Miami, Florida. As speaker this evening, we have Dr. Alvaro Morera. He is the Director of Peer Education for Dermatology at Novartis. We would like to thank our supporter this evening, who is Novartis, for making this educational event possible. Before we begin, a couple of housekeeping notes. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select the phone call in the audio pane and the dial-in information will be displayed. If you're having any technical issues, or if you would like to submit a question to our faculty, please submit your questions in the question pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser, and it also will be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill in this short survey. Also within 1 to 2 days of the webinar, you will receive your certificate of attendance. It will be emailed to you. Again, if you have any questions for our speaker or moderator, they will be talking together at the end of our webinar. Please submit your questions using the question pane on the right-hand side of your screen. So without further ado, I'd like to pass the floor virtually to Dr. Brad Glick.
Well, thank you so much, and thank you everyone for joining us this evening. So very pleased to be here, really on behalf of Dr. Leon Kircik. We have a wonderful educational presentation this evening on psoriatic disease. Next slide, please. So as you know, the International Dermatology Educational Foundation is a nonprofit organization whose principal mission is to raise awareness and improve dermatologic care all around the world through education, especially in underserved areas. This this project was founded by Dr. Leon Kircik, who, as you know, is president of the International Dermatology Education Foundation and has been incredibly committed to providing education for those of us in dermatology over many years, and we really appreciate that. Next slide. So here are some of the previous educational sessions. They've covered the gamut of atopic dermatitis. Recently, we've been doing a number of sessions on alopecia areata and vitiligo. We've had a number of industry sessions, and they've been fantastic and engaging, and you see a number of them here with a wide range of individuals in the field of dermatology. Next slide, please. So really, without further ado, to present see the big picture, seen, unseen, and unforeseen. We have Dr. Alvaro Morera, who's the Director of Peer Education for Dermatology at Novartis. And Alvaro, go ahead and take it away. We very much look forward to your presentation.
Well, thank you so much for having me, and thank you for your commitment to dermatology and the Foundation's work throughout the year. So today I'm going to talk about Cosentyx, and the title of the presentation is Treat the Big Picture. We have divided this presentation in different parts, but first of all, I want to remind you that Cosentyx is approved for different indications, including moderate to severe plaque psoriasis in patients 6 years and older, right? So if you have not seen a Cosentyx presentation in the past 2 years, you will notice that this slide has been updated, right? Last year, Cosentyx was approved for children and adolescents 6 years and older who are candidates for systemic therapy or phototherapy. Moreover, Cosentyx is also approved for adult patients with active psoriatic arthritis. Now, if you're very involved in research and if you follow the news when it comes to healthcare, you will realize that this is actually not up to date, because earlier this year, Cosentyx was also approved for children with active psoriatic arthritis. Now, that is not a part of today's presentation. In terms of contraindications, the only one really is having had a previous serious hypersensitivity reaction to secukinumab. Now, as I said, we have divided this presentation in different parts. The first one we're calling seen, the seen component of psoriatic disease, and that is obviously a reference to moderate to severe plaque psoriasis. Whenever I refer to psoriasis today, I'm referring to moderate to severe plaque psoriasis. The second part of today's presentation, we are calling it unseen. The unseen component of psoriatic disease is psoriatic arthritis. And the third part of today's presentation is called unforeseen. And by unforeseen, we mean the joint damage or the bone loss that might happen in some patients with psoriatic arthritis. Now we're going to start by reviewing the pivotal clinical trials that led to the approval of this drug in adult patients with moderate to severe plaque psoriasis. After that, we're going to transition to 2 additional clinical trials on nail and scalp psoriasis. This is an important slide. As most of you might know, there are risk factors for psoriatic arthritis. We know that patients with nail psoriasis are more likely to develop psoriatic arthritis, and that has been confirmed in several meta-analyses in different international studies. In this particular one that we're showing here, it was described that patients with nail psoriasis were 3 times more likely to develop PSA or psoriatic arthritis. When it comes to scalp psoriasis, in one study, it was shown that patients with scalp psoriasis are 4 times more likely to develop psoriatic arthritis. Now, while this is very, very important, I personally like to remind everyone at this moment of the presentation to follow the American Academy of Dermatology guidelines together with the NPF, the National Psoriasis Foundation. The guidelines recommend screening every single psoriasis patient for psoriatic arthritis at every visit, right? So while it is important to be aware of these risk factors, we should actually be doing a little bit more than that and screening every single patient. There are other risk factors, as many of you might know, that we are not mentioning on this slide. Those include, for example, a positive family history for psoriatic arthritis and having 3 or more psoriatic sites on the body. Now, erasure and fixture. If you have ever seen a Cosentyx presentation, you might recognize these names. If you don't recognize them, it's okay. These are the 2 pivotal clinical trials. That means that the results of these clinical trials were responsible for the FDA's approval of this drug in adult patients with moderate to severe plaque psoriasis. Now, on this slide, I'd like to review the primary endpoints of the clinical trials. Now, while we know that PASI 75 and IGA score of 0 or 1 at week 12 or at week 16 are not necessarily what our patients want to know when we are telling them about a drug, since this is a commercial presentation, we must always review those primary endpoints, right? On both trials, over 80 and 70% of the patients, respectively, achieved a PASI 75 response rate on Cosentyx 300 milligrams. A PASI 75 is an improvement of 75% on PASI score. When it comes to IGA, an IGA score of 0 or 1 means skin clear or almost clear, and that was achieved in both clinical trials by about 2/3 of the patients. Now, of course, because these were clinical trials, the use of topical corticosteroids was not allowed. These are representative photos, actual patient photos taken by the investigators, but I'm sure all of you, as dermatologists and dermatology providers, have seen similar cases very often. Now, these are 2 additional clinical trials. This is what we call a dedicated clinical trial. So this is not a subgroup analysis of the previous clinical trials. These are independent clinical trials that stand on their own with other patients. Transfigure is the clinical trial on nail psoriasis, and the Scalp study is obviously the study on scalp psoriasis. So let's focus on the first one. The primary endpoint is at week 16 and patients were randomized to receive either placebo or Cosentyx 300 milligrams or 150 milligrams. Placebo non-responders were randomized to Cosentyx after 16 weeks. On the second clinical trial, it's a slightly less complicated design. There were only 2 arms. Patients were randomized to receive either placebo or Cosentyx in only 1 dose, the approved one, 300 milligrams. The primary endpoint is earlier. It's at week 12 here. Now, this is a transfigure study, the study on nail psoriasis that showed a strong and long-lasting response in moderate to severe nail psoriasis. Now, week 16 was the primary endpoint. Again, we need to review primary endpoints when reviewing clinical trial data during a commercial presentation. However, most of our patients actually want to know what is going to happen after that. Long-term efficacy and safety data should always be top of mind when reviewing clinical trial data with our patients, right? Now, if we start with the primary endpoint, we see those numbers on that purple box on the bottom left. 46% of the patients on Cosentyx achieved the primary endpoint. That was the mean percent change from baseline in NAPSI score at week 16, compared to only 11% of the patients on placebo. Now, if we look to the purple box on the right, that's the response at week 128, so after 2 years. 72% of the patients achieved that exploratory endpoint, a mean percent change from baseline in NAPSI score. Now, I'd like to remind you that, as I said before, patients with scalp psoriasis and patients with nail psoriasis are more likely to develop psoriatic arthritis. Now, these images are difficult to read, but this patient had at baseline a score of 55. PSSI is similar to PASI, but is specific for scalp psoriasis. The primary endpoint was actually a 90% improvement at week 12. And that was achieved by over 50% of the patients. So 1 in every other patient actually had an improvement of at least 90% by week 12. Very significant data. I will be reviewing important safety information throughout the presentation. Now, if you have ever seen a session like this, the good news is that nothing really changed. So the safety data that we were presenting and reviewing 3, 4, 5 years ago is still the same. While Cosentyx has now other indications, like I said in the beginning, including for children and adolescents, there were no new safety signals in those clinical trials, right? So the safety slides are pretty much the same. Cosentyx may increase the risk of infections. So please remember that when discussing Cosentyx as an option for your patients. If one of your patients on Cosentyx develops a serious infection, you should discontinue Cosentyx until that infection resolves. Now, we are transitioning right away to the second part of today's presentation. That is the data on psoriatic arthritis. Now, I am aware that most of you on this session are either dermatologists or dermatology providers, like I am, but I believe that psoriatic arthritis clinical trial data is actually very, very important when we are making our clinical decisions. So that's why we are reviewing this data today. Up to 41% of our patients with psoriasis may have psoriatic arthritis. Now, how do we recognize it? Cosentyx was approved for active psoriatic arthritis in adult patients based on the results of 2 clinical trials. Those were called Future 2, and Future 5. Slightly more complicated in terms of design than the clinical trials we've reviewed before. But I'll try to make it as simple as possible. On Future 2, patients were randomized to receive either placebo or Cosentyx 150 milligrams or Cosentyx 300 milligrams. The primary endpoint was at week 24. Non-responders were placebo non-responders were randomized to Cosentyx. On Future 5, the difference is that there was an arm that did not include the loading dose regimen. So for those of you who have prescribed Cosentyx in the past, you know that it is a weekly injection from week 0 to week 5, and then a monthly injection, right? If you are not familiar with this schedule, I will review it towards the end of the presentation. Now, in this particular clinical trial, some patients didn't have those weekly injections during the first 5 weeks from week 0 to week 5, right? So that's the light purple arm that you see there. Now, let's start by looking at the purple box to the right, because that's the primary endpoint. The primary endpoint, both in Future 2 and in Future 5, was ACR 20. ACR is the composite endpoint. Not very similar to PASI, but in a way, what it means is an improvement of at least 20% in signs and symptoms of PSA. It's a composite endpoint. It includes different signs and symptoms. That was it. So the primary endpoint was achieved by 63% of the patients on Cosentyx 300 milligrams and 56% of the patients on Cosentyx 150 milligrams, compared to only 27% of the patients on placebo. Now, something that I like to point out here, because that's not always the case when we are reviewing clinical trial data, is that these patients on this clinical trial, some of them had actually been exposed to TNF blockers in the past. So that's what we call a mixed population when it comes to a clinical trial like this. So that's what that purple box to the right says. Now let's focus on the graph. And you see that we are not seeing ACR 20 up there on the title, it's ACR 50. ACR 50 is an exploratory analysis of the clinical trial. It's not the primary endpoint. It is a meaningful endpoint though, because most of our patients wouldn't necessarily just want to know when they can get a 20% improvement. They want to know more than that. 50% improvement, 70% improvement. And we do have that data from the clinical trials. So right here, I'm showing that on both arms, both on Cosentyx 300 milligrams and Cosentyx 150 milligrams, about 40% of the patients achieved an ACR 50 response. Now this is actually only in biologic naive patients. That's not the case when it comes to the primary endpoint, right? So again, about 40% of the patients, both on Cosentyx 300 milligrams and Cosentyx 150 milligrams, achieve an ACR 50 response at week 16. Now what we see below the graphic, ACR 20 response at week 2, that is exactly what that is. So after only 2 weeks of treatment, some patients were already improving at least 20%, and that was the case in 31% of the patients and 26 respectively with either Cosentyx 300 milligrams or 150 milligrams. So overall, some patients do experience a very rapid onset of efficacy. Now, as I said, most of our patients actually care more about long-term data, like where am I going to be 5 years from now, not only what's going to happen in the next 24 weeks, right? And what we are seeing here on this slide is exactly that, the ACR responses at 5 years. Now, let's start at the top. 80% of the patients on Cosentyx 300 milligrams achieve an ACR 20 response. That means an improvement of at least 20% in signs and symptoms of PSA. When it comes to an ACR 50 response, that was achieved by 53% of the patients on Cosentyx 300 milligrams. ACR 70, that was achieved by 35% of the patients on Cosentyx 300 milligrams. On the second line, we see the same endpoints, but for Cosentyx 150 milligrams. Psoriatic arthritis, there's different components, right? The skin is virtually all the time involved, although there might be some patients that actually don't have moderate to severe psoriasis. Maybe they don't even have mild psoriasis when they present with psoriatic arthritis. We don't typically see those patients in dermatology, but they do exist. Now, beyond that, nail psoriasis is actually considered a separate component of psoriatic arthritis. Enthesitis is inflammation in those sites where tendons and ligaments attach to the bone. Dactylitis is the swelling of an entire finger or toe. And let's stop there and review those first 4 components before transitioning to the rest. So in this one clinical trial, Future 5, 71% of the patients achieved PASI 90 after 2 years. 84% of the patients had reduction in nail disease. 80% of the patients achieved complete resolution of enthesitis. 88% of the patients achieved complete resolution of dactylitis. Again, this is long-term data, exploratory results up to 2 years. Now, ACR 50, we have reviewed that. Let's focus on the last key manifestation of PSA. The spine, axial PSA. There is actually a separate clinical trial called Maximize. That's one of my personal favorite clinical trials because it looked into something that most of the other clinical trials hadn't really paid much attention to. And those were the axial or spinal symptoms. I must say that while most of the dermatology textbooks tell us that enthesitis and dactylitis might be present in up to 50% of patients with psoriatic arthritis, I've not seen that very often. I think it really depends on where you practice. I used to work in Germany before moving to New York City. So, metropolitan areas where perhaps access to healthcare is a little different. But when it comes to spinal symptoms, I've seen that very often. Many patients complain of inflammatory back pain. In this clinical trial, 81% of the patients achieved axial relief that was defined in the clinical trial as ASAS 20, that is the primary endpoint. ASAS 20, it's an improvement of at least 20% in signs and symptoms of axial PSA. So again, in this clinical trial, the Maximize clinical trial, and I would highly recommend those of you who treat psoriatic arthritis to look into that. 81% of the patients achieved axial relief, so at least a 20% improvement in signs and symptoms of axial psoriatic arthritis at 1 year. Now we're back to important safety information. Please remember to screen your patients for tuberculosis prior to starting treatment with Cosentyx. If one of your patients has active TB, please do not prescribe or start them on Cosentyx. If they have latent TB, you need to make sure that they receive appropriate therapy before starting on a biologic like Cosentyx. Now, when it comes to inflammatory bowel disease, please remember to screen your patients for inflammatory bowel disease prior and during treatment with Cosentyx. And we have an entire slide with more information on that I'm going to show later on. Before that, I'm going to transition to the third part of today's presentation. And that is what we are calling the unforeseen component of psoriatic arthritis or of psoriatic disease. And that is a reference to the radiographic progression that some patients who have psoriatic arthritis might experience. Now, as all of you know, inflammation in psoriatic arthritis might actually lead to irreversible joint damage. And that is something that we would, of course, like to avoid. Now, the question is, and we're going to talk about that later, how do we even know who's at risk for this type of joint damage? It's a difficult question to answer. Now, I'm going to show data from one of the clinical trials that we've reviewed already, right? So this is actually an exploratory analysis of one of the pivotal PSA clinical trials. What this shows is that patients on placebo experience radiographic progression. By this, we mean patients who had active signs of psoriatic arthritis at baseline experienced the worsening of those signs during the clinical trial while they were on placebo. What we see on the left is that patients on Cosentyx had less radiographic progression, if any radiographic progression at all, at week 24. Now, week 24 is great. What's even better is long-term data, as I've been saying for the past 30 minutes. So I do like this slide a lot, although the numbers are very big. It's like they are screaming at us, but they are important. If we start with the right side of the slide, 81% of the patients had no radiographic progression at 2 years. So this means that while patients had active psoriatic arthritis and signs of radiographic progression at baseline, they did not have any worsening of those signs during the clinical trial while on Cosentyx. So I think that is significant. On the left side, again, we are back to week 24, so perhaps not as relevant as long-term data to our patients, but we see the difference between being on Cosentyx versus being on placebo. 77% of the patients on Cosentyx had no radiographic progression compared to only 68% of the patients on placebo. And again, I need to remind you that this is an exploratory analysis. We've reviewed the primary endpoints a couple of minutes ago. When it comes to exploratory analysis, we should not be drawing any statistical or clinical conclusions. The only thing that we can do is look at these numbers from our own clinical perspective and clinical experience. Now, this feels like a very promotional slide, but there is an important message here. Cosentyx is the #1 prescribed biologic among IL-17 blockers and IL-23 blockers in rheumatology. So what this actually means is that our rheumatology colleagues have adopted Cosentyx as one of their preferred drugs. Now, beyond that, I would highly recommend reading the GRAPPA guidelines. GRAPPA is a research group that actually focuses on psoriatic disease and mostly on psoriatic arthritis, and they put out guidelines regularly. Earlier this year, the updated version of the GRAPPA guidelines was released, and Cosentyx is indeed positioned as one of the first line treatments for psoriatic arthritis, and that's the first time that Cosentyx is in that position. So that again also reinforces the message that our rheumatology colleagues have indeed adopted Cosentyx as one of their preferred drugs. Now we're back to important safety information. Anaphylaxis and cases of urticaria have occurred in clinical trials with Cosentyx. If one of your patients has any type of allergic reaction, I mean, as dermatologists, you know what you have to do. If a serious allergic reaction occurs, please discontinue Cosentyx immediately and initiate appropriate care. Now, what I like to point out here is that the Cosentyx Sensoready pen that I'm going to show later on actually contains natural rubber latex, right, in a specific part of the pen. So we just need to be mindful of that when prescribing the Cosentyx Sensoready pen to latex sensitive individuals. When it comes to vaccines, please consider completing all age-appropriate vaccines according to the most recent guidelines. Now, we have a couple of extra slides on safety. So this is the first one. Take a mental screenshot of this slide, and I'll tell you why in a couple of minutes. Now, the most common adverse events were nasopharyngitis, diarrhea, upper respiratory tract infections, rhinitis, and those infections occurred in 28% of the patients on Cosentyx, compared to only 18.9% of the patients on placebo, as we see on the second table on the right. Now we're back to inflammatory bowel disease. As I said, we were going to review that data. Here it is. So there were 3 cases of exacerbation of Crohn's disease in Cosentyx clinical trials. And by this, I mean in over 3,400 patients. There were 2 cases of exacerbation of ulcerative colitis, and there were 2 cases of new onset ulcerative colitis. So a very low incidence between 0.08 and 0.11 per 100 patient years. However, there were no cases during the placebo-controlled part of the clinical trial on patients that were receiving placebo. Please remember to screen your patients for inflammatory bowel disease prior to starting Cosentyx and during treatment with Cosentyx. Now, I'd like to remind you that Cosentyx does not have a boxed warning, and it does not require lab monitoring during treatment. Now, that doesn't mean that you should stop doing whatever you have been doing, whatever works for you and for your patients and your community. That's just simply not a requirement. The only thing that is required is to evaluate patients for TB. And what does that even mean? There are many different ways to screen patients for TB, as all of you know, right? And you can pick the method that works best for you and in your community. Now, I asked you to take a mental screenshot of one of the slides. Does it look like it's the same one? I think it does, but this is actually not the same slide. This is a different slide. This is the safety profile of Cosentyx in the adult PSA clinical trials. So it looks the same because we have a very consistent safety profile across indications, right? We had a 28 up here, 28% of the patients on Cosentyx had infections. Now we have a 29 on this slide, right? The most common adverse events, nasopharyngitis, upper respiratory tract infections, headache, nausea. And I would like to add that while we are not reviewing the safety profile of Cosentyx in children and adolescents during today's session, that safety data actually pretty much mimics this that we are seeing here. There were no new safety signals in children. Now, when it comes to treating adult patients with moderate to severe plaque psoriasis, most of you are familiar with the dosing. 300 milligrams every week between week 0 and week 4, the first 5 injections, right? However, when it comes to PSA, active psoriatic arthritis, the dose is a little different, right? Actually, the 150 milligram dose is also approved. So in some patients, that dose might be acceptable. Now, if your patients have both active psoriatic arthritis and moderate to severe PSO or plaque psoriasis, you should be using 300 milligrams. Now, if your patients with active psoriatic arthritis don't have moderate to severe plaque psoriasis, you can use both 300 milligrams and 150 milligrams because both of those doses are approved for the PSA indication. Now here it is. This is a sensor-ready pen, and up here, the cap, this purple cap, is actually what contains latex. So if your patients are sensitive to latex, you need to discuss this with them before administering Cosentyx, right? They need to ask someone else or use appropriate gloves. Just need to have that conversation with them. Now, most of the patients, more than 90%, report no pain and no reaction during and after the injection. Nearly 9 out of 10 patients report being either very satisfied or satisfied with self-injecting themselves using the Cosentyx sensor-ready pen. Now, together we have reviewed a bunch of different clinical trial data, right? I am more than happy if each one of you remembers at least one detail of something that we have reviewed today. And I'm going to be highlighting some of the things that I personally consider to be very important on the next slide. Cosentyx has more than 14 years of clinical evidence. That is, of course, including not only the data since Cosentyx was first approved in 2015, but before that, based on the phase 1, phase 2, and phase 3 clinical trials. Over 200,000 patients have been prescribed Cosentyx in the US. And lastly, Novartis has a strong patient support program that basically exists to help your patients getting started and staying on Cosentyx. And please reach out to your sales representatives if you need more information on that. Now, this is the summary. In the beginning of the presentation, we reviewed not only the pivotal clinical trials that led to the approval of the drug, but also dedicated clinical trials in nail and scalp psoriasis. So again, those clinical trials were not subgroup analysis of the pivotal clinical trials, were actually independent clinical trials. And something that I like to point out is that in the scalp clinical trial, some of the patients only had scalp psoriasis. They didn't even have psoriasis elsewhere on the body because the scalp psoriasis was so severe that they actually qualified as moderate to severe patients with plaque psoriasis, right? The scalp is obviously the most common site for psoriasis signs and symptoms. Now, the second part of the presentation, the unseen component of psoriatic disease, again, that's a reference to psoriatic arthritis, that I believe to be a very important part of the presentation for dermatologists like you. I show that Cosentyx actually has data in all key manifestations of psoriatic arthritis. Again, those include obviously the joints and the skin, but also nail psoriasis, enthesitis, dactylitis, and axial psoriatic arthritis or spinal symptoms. And lastly, we review the unforeseen component of psoriatic disease. And unforeseen, again, is a reference to that joint damage or bone loss, that radiographic signs of psoriatic arthritis, beyond the patient's experiencing pain, beyond the joints being swollen. Sometimes there is something going on underneath all of that. So thank you so much for your time, and I'm more than happy to take questions.
Well, Dr. Moreira, that was fantastic. I mean, I feel like I learned so much in this last 40 minutes or so. So thank you for that incredible presentation. And it's not really even just about drug. It's just such a great review that psoriasis is more than just a skin disease for sure. It's really a systemic disease. And of course, the impact on the joints is incredible, which leads me to the first question coming from the audience. Give us your perspective on screening for psoriatic arthritis. As dermatologists, should we be doing this at every visit? And if so, what are the questions we should be asking, and what screening tools could we be using?
That's an excellent question. And my mind goes straight to the recommendations of the American Academy of Dermatology and the National Psoriasis Foundation that say very clearly that we, dermatologists, should be screening all of our patients for psoriatic arthritis at every visit, right? And that includes, obviously, patients that have mild psoriasis, moderate, and severe psoriasis. That also includes children and adolescents, right? So that is the easy answer. I do believe that as dermatologists, it's really up to us to ensure that our patients get the care that they need and as quickly as possible. Now, in the absence of a diagnostic test for psoriatic arthritis, the best thing that we can do is to screen. There is an easy-to-use screening tool named BEST, or the Psoriasis Epidemiology Screening Tool, which is actually a validated screening tool that can help all of us recognize signs of psoriatic arthritis in our psoriasis patients. It's a very simple questionnaire that your patients will fill, only 5 questions. And if they check yes to 3 or more of those questions, that indicates that they might have psoriatic arthritis. Now, at that point, I know that some of our colleagues refer their patients to a rheumatologist, whereas others will just simply treat that component of psoriatic disease as well. And both options are certainly correct.
Fantastic. It's an incredible opportunity to mention the importance of collaboration. I mean, we have to collaborate with our colleagues. This is not only a systemic disease that impacts the joints. From an ophthalmologic perspective, we sometimes see these patients even having ophthalmologic manifestations of psoriatic disease, including uveitis. There's another question that just came up, and it's kind of an extension of what you just discussed, and just wanting your audience, wanting your perspective here. We know that delays in the diagnosis of psoriatic joint disease, psoriatic arthritis, can lead to progression of disease. And so the question is, what is the significance of these radiologic manifestations that you reference? What is the importance of radiographic progression of disease? And where does that play into our thinking as dermatologists? Kind of an extension of the last question.
Well, that's another fantastic question, difficult question. And you and I were just talking about a meeting that we attended a couple of months ago where someone said that, about 50% of the patients with psoriatic arthritis might have radiographic signs of PSA, whereas about 50% don't have that. But the reality is that I don't know when I'm seeing a patient if that patient has bone loss or inflammation around the joints or not. I was very privileged to work my entire career before joining Novartis at big academic institutions where I could just refer the patients, and there were these incredible, I don't know if you ever saw one, MRI machines, very small, very tiny, where the patient can just put the hand inside and it takes an MRI scan of the hand. And you can also do that. There are a bunch of articles that you can also do that with micro CT scans and even with X-rays. But the reality, we don't do that, and most of our rheumatology colleagues in clinical practice don't do that either, right? So it is difficult to know if one particular individual patient is at risk or not, right? So that is the honest answer to that question. Now, of course, what I need to say, because this is a Novartis presentation, is that the clinical trial data that I have presented today on radiographic progression of psoriatic arthritis was on patients that already had at baseline signs or symptoms, signs in this case of radiographic disease. So what we don't know, and I don't want to talk about that, is whether patients may or may not develop that when that is not present at baseline. That has not been studied as a part of the clinical trials that we've reviewed today.
Fantastic. You know, one of the things that you really kind of jars my thinking here is that I know that our rheumatology partners, and actually in Europe, and I think particularly in Italy, a number of our rheumatology partners, especially here in the States, are using a fair amount of ultrasound in their diagnostic assessment and approach to psoriatic joint disease. Let me ask you this question. Now, there's several questions here from the audience. So what about, you know, IBD, interleukin-17 blockers, very challenging. So personal history of inflammatory bowel disease, 17 blockers categorically are out. What about a family history? What's your approach? The person has no personal history, but what is your opinion on someone where there's a family member who has inflammatory bowel disease? What's your answer?
So it's an excellent question. The correct answer is that you need to review that risk with your patient before starting them on a drug like Cosentyx. You can indeed talk to an internal medicine doctor, someone from gastroenterology, and discuss that risk. When it comes to IBD, there are indeed patients that have IBD without having any family history, but it's difficult to know. Not everyone is in touch with their direct family members anymore, so we don't actually know the risk just because, you know, someone in the family has. Is that just one person? Is that multiple people? Does that, you know, significantly increase the risk of our patient develop IBD? I don't know the answer to that, but what I can say is that this scenario is not a contraindication for starting a patient on Cosentyx.
Yeah, because I think even, you know, from the perspective of all these classes of therapies, all 3 of the 17 blockers we have approved, I believe it's a personal history of inflammatory bowel disease. You know, and the challenging thing and what makes the data that you showed tonight impressive is that, as I recall, there's some great work that was done in 2016 by Alex Edgeberg in Denmark. And these numbers that, at least this is just my optics here, these numbers that you reported, these low numbers of inflammatory bowel disease, fall far below what we would expect in a large population of individuals with psoriatic disease, both when we're looking at individuals who have psoriatic skin disease and/or joint disease.
That is true, and I think that has to do with the fact that, you know, as you know well, overall clinical trial patients are a little healthier than the general population. So that could explain in part, you know, that discrepancy in the numbers. That is correct.
The audience is asking for you to comment on different radiologic features that we would see in patients with PSA. You know, what would we be looking for on x-rays? You know, sometimes even we dermatologists will also some, you know, survey type films of the hands, knees, maybe even the spine. What are we looking for, at least in your experience? The audience is curious.
It's an excellent question. I don't think I've ever reviewed that. I've seen that those signs being described as bone erosions, and especially if you're using an ultrasound. I was not talking about that during the presentation, but you brought it up. You can obviously see inflammation in the joints as well. You know, thickness in the soft tissues. So those are the 2 things that come to mind. You can actually bone erosions and inflammation of the soft tissues. I'm sure there are others that you would need to review with a radiologist or a rheumatologist.
Hey, they're stuck with a couple of dermatologists tonight. What else can we do? But I would add in here, when we're looking at the hands and feet, that at least for the audience, we'll sometimes see these as part of the erosive changes later on, the so-called pencil and cup deformities. Especially if there's some residents out there, they like to ask that on board exams. What about, another question came in here about looking at Cosentyx and its being an interleukin-17A blocker. Are there any differences? Is there something that separates it out compared to the other classes of interleukin-17 blockers that we have on the market right now?
So there are. I'm actually not allowed to talk about other drugs during this presentation, but the different approved IL-17 blockers are different. When in terms of being fully human or humanized antibodies, you should definitely look into that. Just I cannot really explore that during a commercial presentation like this.
Got it. Yeah, I think that there's another agent on the market that at least is similar. It's a 17A blocker, and at least for the audience, the only other one is covers really all of the receptors. And I think that a nice comment here is, you reach out to your medical science liaisons for the company. It's very helpful educationally to really learn more about a product. I think from the standpoint of questions, that first of all, those were some great questions. And so I appreciate that from the audience. Absolutely fantastic lecture, really engaging, and I appreciate the opportunity to work with you this evening, Dr. Moreira, as I'm sure our audience does as well. So we thank you and we thank Novartis. I certainly thank IDEF for their participation in these wonderful webinars and these educational opportunities for all of our dermatology providers out there.
Yes, we would like to thank Novartis one more time for making this educational event possible. And we'd also like to invite everyone to register for our next educational event with Dr. Moreira. He is going to be talking about psoriasis again, and we would like for you to see this. This will be a different type of presentation, so we invite you to join us for that on December 6th. Thank you again for joining us this evening, and we hope everyone has a wonderful night.